Hello, Acha. Moderator's missing है, so just waiting for him. We start. Start. Okay. Professor Basma, might I invite you to the moderator desk, please? Okay. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم حسبي الله لا إله إلا هو عليه توكلت وهو رب العرش العظيم اللهم صل على سيدنا ومولانا محمد معدن الجود والكرم وآله وبارك وسلم. I welcome you all to the 23rd Annual Cancer Conference, the radiology section. We have a wide array. Yes. Okay, we'll start. So we have a wide array of really experienced doctors and a really nice selection of lectures for you. Hopefully you're going to enjoy and learn at the same time. Moderating today is, I'm really delighted to finally meet her. I've heard a lot about her, Professor Basma. She's an examiner. You all know that, right? She's a dean in CPSP, head of radiology services hospital. Soon to join her is Dr. Amir Iftikhar, acting head of radiology, Shaukat Khanum, Lahore, and a dear friend of mine. The rules are the same. It's a 20 minutes lecture each and 5 minutes for questions and answer. So without further ado, I am going to invite someone. If you're even remotely related to radiology, chances are that you know him. He does not need any invitation. One of the most famous radiologists in the country, Professor Zafar Sajjad. I myself trained under him when I was in AKU. Professor and Chair, Department of Radiology, Aga Khan University, Karachi. He's going to talk about genomics of brain tumor. Please.
Thank you. Just going to spend the next 20 minutes talking about this. Pretty fascinating area. And I think this is where people really talk about AI and people talk about AI and radiology as if it's going to destroy the profession. But I think it's going to actually save the profession. And I'm going to tell you why. I don't have any conflicts to declare. So we'll briefly go through some definitions because I think there is a lot of confusion around the words that we use to describe what we're going to be talking about. Give a little bit of historical perspective. It was the 2021 WHO classification that really got us to where we are right now. And I'm going to talk a little bit about one of the specific imaging genomic markers, which there is a lot of excitement about. Some of it is, I think, is hype. But a lot of it is relevant, and that's the T2 flare mismatch sign. And then we're going to talk a little bit more about what I initially alluded to as the AI and the impact that it's going to have in what we do. So I think there are there's lots of confusion out there, and a lot of terms are used by people who don't quite understand the exact meaning of what we're talking about. So for example, radiogenomics, until the mid to late 90s used to be the study of radiation effects on the human genome. That's what radiogenomics is. So if you go and Google radiogenomics, all the old studies talk about what radiation does to the human genome, what the mutations are, its effects, et cetera, et cetera, et cetera. And then gradually the use of this term started to change. And it started to talk about radiological features that will predict or are surrogate markers for genomic changes in human pathology. Genomic changes in human pathology are not just related to cancer. There's a whole bunch of other stuff, metabolic problems, et cetera, that are related to the human genome and the variations in it. And we are starting to understand this more and more, and we're starting to look for surrogate markers. Right now, if you want to really prove something, you have to get a piece of tissue out, do a molecular test on it to figure out. The whole idea of radiogenomics is to look at an imaging surrogate marker that will let you predict what the genomic, not just the histology, what the genomic structure is. And radiomics is part of that radiogenomics overall ecosystem. So radiomics is a quantitative measure or a quantitative assessment of the radiological or imaging features that let you predict genomic changes. So what most people talk about when they talk about, especially, for example, things like the T2 flare mismatch sign, what they're talking about really are imaging genomics as opposed to radiomics, and I'll talk about that right towards the end of my talk. So this is what we're trying to do. We are trying to predict what's happening at a cellular level, and we have been trying to do this ever since radiology came along, and we have been pretty good at this. So previous classifications for brain tumors specifically were based largely on anatomical structures, and I'll not go through them, but you can look at all of those, and all of those we had worked out imaging markers or imaging features that let us predict those things. Those were the things, for example, the presence of necrosis or presence of hemorrhage or the presence or the rate of cell turnover or the cell density. We had imaging markers for all of those. And again, just to show you a few examples, you could tell really just by looking at this that this is an extraaxial lesion, and it's more like, and it's not going to be a glioma, right? This was a meningioma, which most of you would know. And this one is an intraaxial tumor. It has necrosis. It has a diffuse pattern, and this is most likely to be a high-grade glioma. We could actually look at things like cell turnover and presence of metabolites using spectroscopy. And looking at this, we could say that given that there is an increased level of choline, this is most likely to be a neoplastic lesion, again, most likely to be a glioma. And if things were in doubt whether this was maybe a lymphoma, maybe not a lymphoma, maybe a high-grade tumor, we could go and look at the presence of intratumoral hemorrhages and use imaging markers to figure out what was happening along the histological classification of brain tumors that we had. And of course, diffusion was a huge game changer and could help you differentiate between cystic tumors like the lesions in the row above versus the abscesses in the row below. And you can see, if I can get my marker to work, you can see that the profound diffusion restriction and this frontal lobe lesion makes this an abscess. And this absence of any diffusion restriction, although the overlap, there is an overlap in terms of the imaging features. One is a tumor and the other one is an abscess. And like I said, we were pretty good at it. We looked at our data. This is going back in 2010. And we got them right most of the time. And then this happened. Do not try and read this off the screen. This is the 2021 WHO classification. And what it did was it changed the basis on which we classified tumors. The tumors are now classified based on their genomic structure. And these were the, and again, it doesn't project very well on this particular screen, but these were the mutations which classified these brain tumors. The most important one of those, I will just list, I will just list, for example, the IDH mutation became the hallmark or the defining characteristic of glioblastomas, and so on and so forth. And the implication of this was that IDH mutated lesions with features of GBM were no longer classified as GBM. And IDH wild type lesions, although they may look like a low-grade glioma, if they carried the TERT or the EGFR mutations, or if they were methylated, or if they had chromosome deletions, even though they didn't look like GBMs were actually GBMs. And this is what we ended up with. So you have three tumors. First row is a tumor that is IDH mutated. And because it's IDH mutated, everything about it, other than that, looks like a GBM, but it's not a GBM. This is a anaplastic astrocytoma. Now, for radiologists or for non-neuroradiologists, that may seem like a very small difference, but in terms of outcome for the patient, it has a huge implication. GBM, the average survival with best therapy is about 4 years. With anaplastic astrocytoma, with the best treatment, it can be up to a decade, right? So it's a huge impact on patients of what you call these things and how the surgeon is going to deal with them. This one on your right is the classic GBM. This is IDH wild type. It has necrosis. No problem with this one. But look at the one in the middle. There is a tumor. You can hardly see it, even on the flare. There's a little bit of diffusion restriction. There is no change or no significant hypervascularity. So everything says that this is a low-grade glioma, except this is IDH wild type. It has TERT2 mutation, and it has chromosome 7 deletion. This is a GBM. This has to be treated like a GBM, even though it looks like a straightforward thing. And this is what really kicked us in the goolies. And there was a whole bunch of stuff that happened after this. There was a wild scramble to try and figure out, how do we do this? How do we figure this out? And what they came up with were the genomic markers. So there were markers for IDH mutation, there were markers for 1p19q co-deletion, methylation, EGFR, et cetera. But you will notice that there is a lot of overlap in these. There is a lot of overlap. But one thing which got a lot of people talking was this T2 flare mismatch. And the T2 flare mismatch is described as a homogeneously or near homogeneous hyperintense T2 signal with a low signal on flare with an hyperintense rim. And I'll show you an example in a minute. And what this is supposed to be a marker for is an IDH mutated 1p19q non-co-deleted tumor. So this is a marker for low-grade gliomas, which are not oligo. So remember, 1p19q co-deletion is a marker for oligodendrogliomas. If you do not have this 1p19q co-deletion, it's not an oligodendroglioma, right? So these are the classic old-style low-grade gliomas. If you have this feature, this is what you're dealing with. The problem is you don't very often have these features. So this is what it looks like. And the reason I'm using a published case is so that because we have issues with how ADH mutations are looked for. And a lot of times when we say that these are non-mutated, they are not adequately tested. I'm not talking about working in Pakistan, they're not adequately tested. And therefore, sometimes you don't really know because of the cost implication, because of various other means. I'm not really an expert in that, but the testing for the code for the IDH mutation may not be as robust as we need it to be. But this is, and a published example from AJNR, this is somebody who has a IDH mutation with a 1p9 with known co-deletion. So this is what the mismatch looks like. This is not what the mismatch looks like. This is a GBM wild type, and you can see that although there is some T flare hypointensity, a lot of that is because there's blood in it. And there has been a lot of work done on this, because this is, from the imaging genomics perspective, this is the most easy and uh, um, the easy one to look at and the easy one to study. So there has been a lot of work and there's a lot of publications on this. And overall conclusion is that it's highly specific, not very sensitive, and it really works for the old style low-grade gliomas, like I said in the beginning. The problem is a lot of people call stuff like this T2 flare mismatch, and this is not T2 flare mismatch. So although you have an area of flare hypointensity in an area that is T2 high, it does not fulfill the criteria. This is a very heterogeneous lesion, and there is no peripheral T2 peripheral hyperintensity on flare around the area of the mismatch. And this is obviously does not fulfill the criteria for you to call this a T2 flare mismatch, but a lot of people do still call it. So how does this work in the real world when you're non-neuroradiologist reading it? It still works pretty well. It's still, even in an unselected group of patients, this works pretty well for, which still remains highly specific for IDH muted 1p19q non-codeleted tumors. So it is, of all the imaging genomic science, this is probably the best studied and the best one that you could apply in your practice if you wanted to. But of course, remember, you have to take things in perspective, and things which look like the classic sign. So this is hyperintense on T2, hyperintense on flare, has the T2, has the bright rim, but this is obviously an abscess, right? So take things in perspective, look at the overall things. The classical imaging appearances still hold true. Radiogenomics will come as a second step, and do not use advanced features to overrule what your classic anatomical imaging is trying to tell you. This is what we struggle with the most. And this is where imaging genomics fails most of the time. This is the IDH mutated tumor, the IDH wild type tumor that looks like a low-grade glioma. This is where we struggle. And if you look at it, so this particular study looked at various things. How do you differentiate between mutated and wild type tumors? And if you could look here, most of these do not reach statistical significance. Some of the things which do is multifocality, and then down here, the fact that it's located in the brainstem. But most tumors that we deal with will not have these features, right? So trying to use these features to differentiate them does not really work. And when they did a multivariate analysis, and then this is another group working in the US, and you can see that if you had all of these are about 25 of them there. If you had all of these, you would then start to get into an area where you would be able to predict these with any degree of certainty. And this is not really humanly possible for you to do this just with your eyes and your brain. And this is where radiomics comes in. And what radiomics does is it takes the image, it segments it out. And you can do this manually. You don't have to use an AI tool to do this. You can do this manually, but it just takes forever to do this manually. So you have your medical image, you segment it, you extract features, you put those features through a statistical test, and the statistical test will then tell you the likelihood of this being what you expect it to be or don't expect it to. This is how it does it. And you can do this many ways. This is the classical textural map, and this is what the classical textural map looks like. And on here, all they have done is they've taken a T2 image, they've taken a T1 image, and they have used 4 characteristics or 4 combinations. So they have said T2 hyperintense, T1 hyperintense, T2 hypointense, T1 hypointense, and then obviously T1 hyperintense, T2 hypointense, etc. Right? So four possible combinations. You can, on these two, they have mapped them, they have done a statistical analysis, and they've come out with a diagnosis, or they've come out with a prediction, not a diagnosis. They've come out with a prediction as to what it's going to be. And this, if you were to do this manually, will probably take you 3 days to do. AI does this in about 35 seconds, and it's going to get better. And this is what I think is going to be the impact on AI. We did an online seminar with Khan Siddiqui, who is one of the pioneers of imaging AI. And one of the comments was that AI is not going to replace radiologists. Radiologists who use AI are going to replace radiologists, which I think is absolutely what's going to happen in the future. And then you have to go through the models. You have to first create the model, train the data, and then validate it. But this is pretty standard AI workflow. And a group from AKU actually looked at the performance of these. And although they are still fairly primitive in where they should be, they work at all of the three important things when you come to working with brain tumors: characterization and grading, prediction overall response and survival, and looking at the mutations and biomarker status. So AI is getting there when it comes to actual tissue characterization. So with that, I'll conclude by saying that classical imaging parameters are still very relevant. Do not ignore them. They're still very relevant, even in this day of genomic classification of brain tumors. T2 flare mismatch sign is specific for IDH mutated non-codelated gliomas. The other genetic markers are a little bit more difficult to do manually or by just eyeballing them. But I think the application of textual analysis and AI techniques will really modify how we read this. Thank you.
Thank you very much, Prof. In addition to T2 flare mismatch, Dr. Frank Gaillard keeps stressing on ADC values as well when we are trying to determine high grade or low grade, especially when we know it's not an abscess.
Yeah.
So is that of any significance?
It is. So we tend to do that, but the problem is that there is still a significant overlap, especially when it comes to the IDH wild type gliomas, which are still early on in their development, so to speak. So the tumor may look, and the example that I showed you, again, the reason I showed a published one is so that we have, the problem working at AKU is a lot of times we image, but we never get the histological outcome of those. So it becomes very difficult to show those with any degree of certainty. I may think that this is what it is, but I don't have histological proof of it so far. So that's why I use that. And if you remember that example, the ADH value for the midline, or the ones, the middle column, was actually the same as, was not significantly different from the astrocytoma. And so, yes, it is, but there is an overlap, and that overlap may, but from a practical purpose, I would use that every time.
And a reality-based question. So when we are reporting on a daily basis, and T2 flare mismatch, let's say, is non-significant, should we even say high grade or low grade? Like, obviously, it's now almost completely based on IDH mutation.
Yes, but again, remember, you can have high-grade gliomas which are which are mutated, right? So the so-called anaplastic astrocytoma is a high-grade tumor. It is WHO, old-style WHO grade 4 tumor, but it is not a GBM simply because it has the IDH mutation.
It should be in our.
Yes, so if I see necrosis, and like I said, the classical sample, this classical descriptors are still relevant. So if I see hemorrhage and if I see necrosis, I will go ahead and say, this is likely to be a high-grade glioma. I will not use the word GBM. So one thing which I have changed actively in my reporting is I almost never call anything GBM based only on imaging. I've stopped using the word GBM in my reports in terms of imaging.
Okay, thank you so much, Prof. That was absolutely fantastic. Okay, so next up is a online lecture, a recorded lecture, but I hope Dr. Ghaus is present himself. So this is from Dr. Ghaus Ali Sayed, Colonel Ghaus Ali Sayed. He's the head of radiology from RMI Peshawar, a senior colleague of ours, and he's going to talk about osteosarcoma and Ewing sarcoma, our daily struggle. So how can we differentiate based on radiology? So we're going to learn from his experience.
Diagnosis of bone tumor due to its sensitivity to detect the bone matrix and its Bowman pattern. The classical signs related to the malignancy on conventional plain radiography include sunburst periosteal reaction, onion skin periosteal reaction, Codman triangle, and the permeative pattern of osteolysis. Radiographs should be followed with cross-sectional imaging for initial evaluation of the tumor and also for the treatment of the response to the therapy. MRI is the preferred imaging technique for the study of bone sarcomas, which is accomplished by using anatomic and functional MRI techniques. Now to show a few typical pattern of periosteal reaction and outlook of these tumors, when to call it malignant. In this, you see this destructive pattern, osteolysis, and lot of soft tissue involvement. In this image, classical sunburst appearance of periosteal new bone formation, permeative intramedullary restriction, and new bone formation. Large soft tissue component, and you see the local very appreciable swelling. Another case with a lot of scalloping and gross cortical destruction, Codman triangle, and intramedullary extent, this permeative type, then this sclerosis involvement of the epiphysis and soft tissue bulge. The benign features include narrow transition and sclerotic margin in spite of all these osteolytic areas. The sclerotic margin and sparing of soft tissue is very, very suggestive for the benign features. The role of MRI is paramount. Now, the MRI is the modality of choice to assess the bone sarcomas for diagnosis, for monitoring of the recurrence and the tumor response. Anatomical sequences including T1 and T2 weighted imaging, and they provide morphological assessment that is crucial to localize the tumor and to describe the anatomical boundaries. Multiparametric MRI provides functional information that helps in the assessment of tumor response to the therapy by using the different imaging sequences and biomarkers. Anatomic MRI sequences provide anatomic details and informations for accurate assessment of the local disease, including extent of intraosseous involvement, soft tissue component involvement, and the extent, especially a lot of knowledge about neurovascular bundle involvement and a know-how about the skip lesions. Then at the end, the lymphadenopathy also. You see on plain X-ray, the trivial finding of this dense soft tissue mass-like looking opacity and almost poorly perceivable medullary derangement of the woman pattern. And now you see on MR how markedly evident is all the horrible lesion on MRI stir sequence. Another case, you see the limited information on plain X-ray, but not missable. And whenever anything found, even such trivial abnormality on plain X-ray, never ever miss to further evaluate this on MRI of the part. And you see on MRI, extensive soft tissue involvement and very evident such extensive lesion. And when compared with the opposite side, the abnormality is so obvious. Another case with very obvious lesion on plain X-ray, but utmost details on MRI. You see the medullary extent, the lesion composition and the soft tissue involvement. And you can have all the details of the various muscular compartments also at the same time. Now talking of the osteosarcoma. This is the most common malignant bone tumor in childhood and adolescence. The incidence of osteosarcoma has been increasing by about 1.4% per year for the past 25 years. Various documents indicate this, but I'm of the opinion that this is probably due to the increased detectability, increased imaging, increase in population, and I think the overall ratio remains the same. It is our detectability which has markedly increased with the passing years. 15% of all primary bone tumors and 0.2% of all malignant tumors in children is the osteosarcoma. Boys are affected 1.5 times more than girls, unlucky boys. Age, the peak incidence is the second decade of the life. Location, about 80% of osteosarcoma occur in the extremities and with the most common site being around the knee joint. About 80% of the cases have localized tumor at presentation, whereas the remaining 20% most commonly with the pulmonary metastasis. The clinical presentation is very variable, and the most common clinical symptoms at presentation is the pain, generally described as dull or aching. Other common complaints are swelling or the palpable local mass. Occasionally, there may be elevation of the serum lactate dehydrogenase and alkaline phosphatase, or both. The diagnostic pathway is to be followed is plain radiography first. It is the first diagnostic study should be done, which will show the destructive lesion and most typically in the metastasis of the long bone in case of these osteosarcomas. The plain radiographic appearance is typically highly suggestive of malignant process. The amount of ossification in the lesion on radiograph varies. and therefore can be difficult to differentiate from Ewing sarcoma in many cases, or even the infection. MRI nowadays is the primary, very important imaging modality of the primary site, and usually the next radiological study to be performed. MRI is optimal for evaluation of intramedullary and extraosseous extent of the tumor and its relationship to the neurovascular structure. This is the most important point for the surgery point of view. These relationships are important in planning the biopsy and also the limb salvage surgery. CT chest for detection of earliest possible metastasis. Radionuclide whole body bone scans important for the skeletal metastasis. PET scans are being evaluated both for the treatment response and follow-up of suspected recurrences. Biopsy. Keep in mind, the definite diagnosis and treatment plan must always be based on tissue diagnosis. Biopsy may be done either with the needle or it may be an incisional biopsy. Now, important prognostic features of osteosarcoma are number of lesions, unilateral disease, time since initial treatment, most importantly, the complete surgical resection of all disease. Although many patients with the osteosarcoma are cured with the with their initial treatment, approximately 30% will have a relapse, most commonly in the lungs. Other common sites of a relapse include the local recurrence and skeletal metastasis. The long-term survival after pulmonary recurrence is 25%. Now, to show you a few cases on plain X-ray and MRI of osteogenic sarcoma, in this case, you see the osteogenic component infiltration of the soft tissue, the Codman triangle, and the permeative osteolysis, the typical site of metaphyseal region, and knee, no doubt. Just to show you how it looked like on plain X-ray, the typical sunburst periosteal reaction and outlook on the MRI. Just see the detail of the intramedullary extent and this Kiplian, which is not so perceivable on the plain X-ray. So the MRI is mandatory for the fullest evaluation. Another case, to just give an idea about the intramedullary extent and the involvement of the soft tissue. Extraosseous component to highlight the exuberant new bone formation in the soft tissue, at the same time involvement of the metaphysis of the tibia and destructive process of the cortex. Classical sunburst appearance in another case, and outlook on MRI. Another case to show you the extraosseous osteosarcoma. You see the bones are unremarkable, the joint is unremarkable, and the axial scan shows quite apart the lesion from the adjacent bone. Telangiectatic osteosarcoma, you see the multiple cystic foci and this extensive heterogeneous pattern on both the sequences. Another case. Now, a brief resume about Ewing sarcoma. This is the second most common malignant bone tumor of childhood and adolescents. 2% of all cancer in children and young adults. The overall incidence has remained stable over the past 25 years. They comprise of small round cell blue cell tumors thought to rise from the neural crest cell together with the malignant peripheral neuroectodermal tumor. They make up to Ewing sarcoma family of tumors. More common in male and than in female patients, just as in case of osteogenic sarcoma. In 95% of cases, there is a translocation of T11 to 22 or Q24 to Q12, which is detected. Location in case of Ewing sarcoma, the skeletal distribution is evenly distributed between the axial and the appendicular skeletal and in long bones. The diaphysis is the more typical location. The clinical presentation like osteogenic sarcoma is the most common presenting symptom is the pain, local mass. Fever and weight loss can be seen in larger tumors, leading to the inclusion of osteomyelitis in the differential diagnosis. Some patients may have an elevated WBC, ESR, or even LDH. Diagnostic pathway, you see it is just the same as in case of osteogenic sarcoma. First is the plain radiography, then MR is mandatory for fullest evaluation, then for metastasis, CT, bone scan for skeletal involvement, and then PET scan for recurrence and re-evaluation, and the therapy response, and then biopsy is definitely mandatory. To show you few cases, typical outlook of Ewing sarcoma, the diaphyseal location, and you see the extensive involvement of ulna in this case, the typical onion skinning and hair and on panther. Extra osseous component to show, which is large one, but in this case, the humeral metaphyseal region and the head region is involved. Lot of soft tissue component is there. Another case showing the skull, extra osseous component is larger one. Then in case of femur, typical involvement of metaphyseal region and onion skin appearance and scapulian on MRI. Periosteal reaction, classical in case of Ewing sarcoma, the onion skin appearance. In another case, in case of chest, you see lot of large extra osseous component. In fact, the whole right hemithorax may become opaque due to pleural reaction and pleural effusion or bleed. Then in case of proximal end of femur, you see the marrow extent poorly detectable on plain X-ray and highly detectable with full extent on MRI. And the soft tissue component and whatnot, involvement of the epiphysis, and you can see the compartmented detail on MRI. And this is the paramount importance for surgical proceeding. In case of pelvis, lot of intrapelvic soft tissue component, destructive osteolytic lesion of the right iliac bone, and you see the displacement of the other viscera, involvement and encasement of the neurovascular bundle. Okay, now at the end, how to differentiate between Ewing sarcoma and osteosarcoma. You see clinically all the features, all the outlook is just with a lot of shades of gray, lot of overlapping, almost similar things, nothing is specific. Location wise, okay, the most commonly osteogenic sarcoma in lower limb and around the knee. In a study of 1,233 cases, 80% are the bone tissue, bone tumors, and 15% are extraskeletal sites in case of this osteogenic sarcoma. The other study for Ewing sarcoma shows a little variation, but not as important, just to differentiate on these features. Take-home message is to differentiate between imaging osteogenic sarcoma and Ewing sarcoma on imaging is not possible. Simple as that. However, few points should be considered. On T1 weighted images, osteosarcoma usually shows a sharp transition from normal fatty marrow to hypointense tumor marrow involvement. Ewing sarcoma shows a wide intramedullary transition between the tumor and the normal bone marrow. Soft tissue masses. Ewing sarcoma is associated with soft tissue mass in 96% of cases. Osteogenic sarcoma, on the opposite, tends to expand the medullary cavity and bone formation. My resources for all this were the RMI packs, radiographics, and ADR. These are my references. Ladies and gentlemen, if I was unable to come to Lahore, I want to invite you to Peshawar and just to give a look of my prestigious institute. RMI, this is the old building called SH building, and this is the new building, another one opposite to the old building called GH building, hosting teaching institutes and academic blocks, and our own radiology department also in this new building. This is our main radiology department, main reception and general waiting area. And our motto in the end, पूछते हैं लोग मुझसे क्या है तेरा मशगला, रोशनी तकसीम करना, जुगनुओं को पालना. Thank you, gentlemen.
Unfortunately, Dr. Ross is not online at the moment, so we probably can't have questions. Just my 2 cents as a MSK radiologist. So if you see a diabetic lesion in an age-appropriate patient, look at the tumor load. If it's more diaphyseal, less metaphyseal, it's going to turn out to be Ewing. That's just my own observation, which is about 90% accurate. And if it's more metaphyseal, less diaphyseal, it's going to turn out to be an osteosarcoma. In reality, the distinction is actually not that necessary because the treatments are the same. But for the people who are about to sit your exam, as soon as these are usually easy scoring questions, as soon as you see one, you know what it is. Say it's either Ewing's or osteosarcoma, and make sure that you say what you're going to do next. I'm going to do an MRI with a T1 of the whole limb to look for skip lesions and a chest X-ray to look for chest metastases, okay? Make sure, because they know this is an easy case. If you don't do the second part, you're probably going to fail your question, okay? So, yeah. Mike. Ek dafa.
I think the one thing that you just kept, I think that the pulmonary metastasis of osteosarcoma also produce pneumothorax.
Yeah.
That's very important. And secondly, we have a second peak of osteosarcoma.
Yeah, a late one.
A late one, and that's usually due to radiation or some other underlying pathology.
Yeah, absolutely. Yeah, radiation-induced osteosarcomas. Okay, that's excellent. So when we are talking about chest, when we are reporting chest, there's one thing we are really scared to do as radiologists. You guys who are at the end of your training, you know that, right? When we see a lung mass, When we see anything else in a muscle or whatever, we say it's amenable to biopsy, it's resectable, blah, blah, blah. But we never say that when we see a lung mass. That's because we really don't know if these are resectable or not. To answer this question, I invited my senior, my colleague, my mentor, and my brother, Dr. Azanjan, head of cardiothoracic surgery, also from RMI.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Thank you, Dr. Shahzad, and the audience and the Shaukat Khanum Hospital for arranging the conference and letting me speak at this occasion. I will take a different perspective to discuss with our radiologist here, the surgical perspective. The one thing, as Dr. Shahzad said, I work at the same hospital with Dr. Ghaus, and we regularly do MDTs on all our patients, and that really matters. I got trained, especially in oncology at MD Anderson Cancer Center in Houston, and they are really at the forefront of writing all sorts of guidelines for treatment. But really, one thing that they have been practicing, and what I really learned from them and teach now, is that currently the cancer treatment is not really imaging based or history based or so much. It's everything together. It's a personalized treatment. There's no such thing as a standard treatment of lung cancer anymore. So every patient has to be taken individually, and all the factor has to be taken, and the treatment should be tailored according to the patient. It is difficult. It takes more time. It is harder to learn for us also. But the most important thing is this has a real impact on patients. The question that was posed to me today was resectability. Surgery was one of the earliest treatment that was started for cancer. And I would say that even till date, the real impact on survival has still been only surgery. All the other modalities of treatment has had an impact, but not as much as surgery. So with that regard, as surgeons, we have always been pushing the frontiers farther and farther in terms of resectability, in terms of what we can do for our patients. And this is something that I'll be discussing today, that what we can do today in 2024 and what we can do in Pakistan, and how we can make this impact. So I sort of split my presentations in these steps, the criteria for resectability. Then focus specifically a little bit on chest X-ray, solitary pulmonary nodules, and then we'll move on to staging and METs. So the first point I want to make is that everything can be resected. I mean, the only thing in the chest I would say is considered unresectable today is the right and the left ventricle. Apart from that, everything else, pleura, pericardium, even the atrium, even the SVC, IVC, we have resected that with cancers. So remember that anatomical boundaries are now gone beyond that. The question is, resectability is more for the patient benefit. As a surgeon and as our anesthetic team today, we can do everything. But the question for us is, will this benefit the patient or not? So some factors are patient related, which includes the lung function, the age of the patient, the frailty of the patient, any concomitant major cardiac or any other major organ, vital organ disorder present. But as far as specifically images is concerned, the most important thing is staging. But the issue with staging is that it does not always correlate perfectly with surgical resectability. What I mean is T4 stage does not mean that surgery cannot be done. So similarly, we've discussed osteosarcoma and METs and lung METs. Again, for years now, we have been able to resect different METs, osteosarcoma, one of them. What we look on the imaging is invasion of the mediastinum. Any chest tumor, any lung tumor. The problem is the CT is not very accurate in mediastinal invasion. The other important factor is major vascular structure, the aorta. So it was thought that if more than 90% encasement of the aorta is there, then it's a non-resectable cancer. But that's something I will discuss also. It's not anymore. Another, as far as imaging is concerned, there's low accuracy between contiguity and invasion of the aorta. So that has to be kept in mind. So as I mentioned before, all these factors from histology to type of cancer to the patient condition, all has to be taken in before making a decision of resectability. So this is a case with the tumor, it was invading the aorta, and this was resected and the aorta was replaced with a prosthetic graft. According to the SEER database, the resection rate of T4 tumor was 9% with the overall 30-day mortality of 10%. The database also showed the survival rate has increased from 15 to 35%. So as I was mentioning that the resectability criteria is constantly changing and we're pushing the envelope further and further. So chest X-ray is always the first X-ray, and that really prompts the workup as far as the imaging is considered, based on the pattern seen, based on the volume and lung distribution. It gives us a fair idea that which direction we need to move in. The most common thing that comes in terms of imaging is the pulmonary nodules. Pulmonary nodules can be benign and malignant, and the biggest question for us and for imaging both is that which nodules are malignant, because when they are malignant, then we should go for resectability. So on CT scanners, about half of the smokers aged 50 years may have 1 to 2 millimeter nodules. So less than 3 millimeter are labeled as micronodules. And the frequency also depends on the area you're living in. If there's more granulomatous disease in an area, you will see more nodules on imaging, and it makes it even more confusing for us. As an oncology surgeon, the most common presentation to the patient for us is the patient has been diagnosed with a mass or a nodule years ago, and someone told them this would be TB. And they have been treated for TB for a year, because usually treatment is 6 months to 9 months. By the time they come us, it's gone from a very early stage cancer to sometime non-treatable. So early on, differentiating benign and malignant is very, very important, because the tumor turns non-resectable if presented late. Remember, the most common solitary nodule is the prominent nipples, both men and women, and it can be even one depending on the projection angle. So this also confuses at times. So what factors are important? The first of it is calcification. Calcification is a high probability that the lesion is benign. On the other hand, the second thing is the size. The greater the size, if it's more than 20 millimeters, 75% is malignant. So size is very important. Doubling time is also very important. Bronchial carcinoma takes about 1 to 18 months to double the size. So comparing it with previous imaging is a very important factor. Fat in a nodule is a reliable sign of benign disease. It's a hematoma or lipoma. And location. Most primary malignant nodules are located in the upper lobes, especially on the right. But metastatic nodules, 2/3 are present in the lower lobes. The other thing we look at is the margins. Most malignant nodules present with irregular and spiculated margins. And the most important, those tumors that are presenting as cavities, then we look at the wall thickness. So with these factors, you can have a fair idea that which nodule is malignant. If it's malignant, then it needs to be resected earlier possible. Depending on the size, either we do lobectomy or segmentectomy. So the next thing after X-ray is the CT with IV contrast, because it tells us about the TNM staging. It also gives our information about the associated conditions, and also facilitates if there's additional biopsy planning about the location. So for metastatic evaluation, it is most experts agree that patients with suspected lung cancer, imaging potential mets is important. However, the approach to such imaging lacks high standard evidence and is not standardized. That's why we see variable approaches in different institutes about how to evaluate METs. So the two common approaches are, one is known as a comprehensive approach and one is known as a clinically based approach. Comprehensive approach means every suspected lung cancer patient gets a CT chest, a PET CT, and a brain MRI. This method has superior sensitivity to detect occult METs and a possible reduction in unnecessary surgeries, but a relatively high false rate and lack of standardized criteria for positive, and obviously the additional cost. Compared to that, the clinically based has a high negative predictive value and a low cost. And as far as the clinical approach is considered, these are things we should be looking at, some symptoms and some signs. If there are constitutional symptoms of malignancies, of weight loss, night sweats, skeletal pain, neurological symptoms of headache, syncope, which are unexplained, or seizures. Similarly, unexplained pleural effusion, lymphadenopathy, which is very large, hepatomegaly. Those signs should tell us that we need to do more comprehensive imaging for these patients. The problem with lung cancer is that it presents in all different shapes and sizes. And I mentioned before that it's commonly confused with TB in Pakistan. And TB similarly presents with all sorts of shapes and sizes. And that is one of the most important reasons for belated patient presence for oncology surgery. And that is one of the main predictors of non-resectability that the patient presents late to us. So the common appearances, as you know more than I do, are mass with lobulated margins or spiculated margin. But at the same time, if you look, there are uncommon appearances like cavitation with thick walls, ground glass appearances. These all are different types of adenocarcinomas. So it's really not one picture that fits the cancer or the lung cancer. And that makes this disease even a very more complex disease to deal with. So a very high index of suspicion, anything abnormal on imaging should be checked, should be biopsied, should be followed. We cannot really sit relaxed on it because we're already missing all these cancers. So this is a picture of a N3 tumor with the lymph nodes on the other side. Once the lung cancer crosses the midline, mostly it becomes non-resectable. Mostly, I mean, is at least surgery should never be done as upfront. They may respond to chemotherapy and may become surgical candidates. But as long as it is in the one chest, then surgery is offered usually as the first. Once it crosses the midline, then surgery is not the best first option. There is debate about PET CT. There are studies which show that PET CT decreases the rate of thoracotomies, which are known as futile thoracotomies for benign diseases. However, randomized trials evaluating the association between PET CT and therapeutic outcome has had conflicting results. Some have shown benefit, some have not shown benefit. We in Peshawar do PET CTs, but previously patient used to come to Lahore. And many, for all the cost and other issues, we sometimes would have operated on them without PET CTs. Now that it's available in Peshawar, we have done more commonly now. But the data is open. Both approaches are acceptable, I would say. The use of PET CT have increased. So with the exception of brain mets, whole body PET CT to a greater degree is more sensitive than CT alone in detecting tumor invasion, occult disease, lymph node involvement, and intra and extra thoracic mets. However, this all have not shown to improve survival. Picking up those small tumors have not shown that it really changes the outcome of the patient. So even as surgeons, they sort of split. I tell you what we did in America was that every lung cancer was getting a PET CT. But at the same time, I'll accept that the data is not 100% in favor of it. And maybe experts here can guide us on that also. Just two cases I want to discuss just to highlight what happens in Pakistan. So this is a gentleman, a 50-year-old male who was diabetic, poorly managed. And here this X-ray imaging and was correctly followed with a CT scan. And the most common patients that come to us for malignancy actually turn out to be benign disease. Benign disease is more common in Pakistan as far as surgery is considered. This was a pulmonary artery aneurysm, and we ended up doing a lobectomy and resecting of the aneurysm of this patient. Another patient, this is a 60-year-old male with actually very vague history, prolonged history of left chest pain. And there was this abnormality on the X-ray on the left side with the claustrophrenic angle was not very clear, but no other systemic symptoms. And when further imaging was done, there was this huge mass in the left lower lobe. Biopsy was done. We did lymph node evaluation. It turned out to be spindle cell carcinoma. So the point I want to make here is that even though you can see that these cancers have been listed as very rare cancers, but as a surgeon, I can say that those that get operated in Pakistan, they have other diseases than the common non-small cell cancer. In my 10-year experience in Peshawar, only 2 non-small cancers have come to us, which has been resectable, and we did surgeries for them. Every other patient are too late to present. And all the other cancers that we have operated are something that so-called are very rare. So for us surgeons, the rare cancers are more common. The common cancers are less common for us to operate on. So this is how the patients present in Pakistan. So we really need a good, strong screening program, low-dose CT scans, etc., strong suspicion, good follow-up on X-rays. And really, we have to think in terms of whenever we think of TB, we should think of cancer also. I think that really has to be changed to increase the resectability of our cancer patients. Thank you very much. Any questions?
Yeah. Besides, can you hear me?
Yeah.
Okay. Besides the point that if a tumor crosses the midline, it's irresectable, what are the other features that make the resectability a little difficult? Like invasion of the vessels or the cardiac invasion or,
Yes. So I'll answer it in 2 ways. One is as a surgeon or as a department. So resectability, very important factor is the surgeon and the hospital. We being a cardiovascular and thoracic department, we do aortic surgery, heart surgery, and thoracic surgery within one department. For us, the resectability criteria is very different. In general, if you send a patient to a thoracic surgeon only, they will never touch the aorta, they will never touch any SVC, any vessels. But what we did in MD Anderson and what I do in Pakistan here is, if all other criteria fulfill, I can resect any of the vessels and reconstruct it. So resectability is based on the surgeon, it's based on the institute, not only the cancer. Coming to the point of which patients would benefit from resection, all I can say is once they cross the midline in a way that there's a gross tumor, for example, gross tumor in the pericardium, gross tumor in the other side, then those are non-resectable. Like patients would not benefit from any surgery. But if it's just only one area, if they're invading the SVC only, if they're the right atrium in just one area, that all in current age is resectable. But I'll tell you that, for example, I'll tell about KPK that only our hospital can do it. So if you send him to any other thoracic surgeon or even oncology, they will tell them that you are not resectable. So that's part of it. You have to make sure that you send him to the right who can do complex cases. So
thank you very much.
thank you.
Thank you very much, Dr. Azamjan. That was very important information. We've been waiting for someone to tell us about that. So I'm gonna go with Dr. Fatma Mubarak next because she's online. We have a really good brain cover today. So we've had glioma explained in great detail by Professor. So next up is lymphoma, brain lymphoma, again emphasizing the WHO classification. by Dr. Fatma Mubarak, Associate Professor, also from Aga Khan University.
Assalamu alaikum. My name is Fatma Mubarak. I'm an associate professor of radiology at the Aga Khan University Hospital, Karachi, Pakistan. I'm thankful for the Shaukat Khanum Scientific and Organizing Committee for inviting me here as a guest speaker. This is the presentation on the imaging of CNS lymphoma, an update, and what does the WHO classification of CNS tumors 2021 and hematolymphoid tumors 2022 says. So there is nothing to disclose. The cases which I am going to present in this presentation are from the Aga Khan University Hospital and the Singapore General Hospital, from where I did my training. So actually, we all know, like, the lymphomas of the CNS are the second most frequent primary brain malignancies in adults after gliomas, and pre-surgical suspicion of lymphoma greatly impacts patient management because the steroids need to stop if they are giving steroids to the patients, and biopsy does the all work. And then there's role of chemotherapy and radiotherapy, not like the gliomas, in which the surgeon needs to resect, do the safe marginal resection or the cross total resections. So the outlines for today's talk are the WHO classifications, their insights and updates, spectrum of lymphomas involving the CNS, some real cases, and the imaging of key CNS lymphomas. I'm talking about some of the good to know or key concepts, then the key points and the take home messages. So about the WHO classification of tumors, 5th edition, particularly about the CNS lymphomas. So it falls between two 5th edition WHO classifications, the CNS and the hematolymphoid. And the histology of the biopsy specimens remains the mainstay despite the impressive advances in molecular pathologies. And now there is a paradigm shift. Now there is a change in terminology. They use 3-part nomenclature like the histological lesions, the involvement of the oncogenic virus, and the immune background of the patient. There's also a concept of immune sanctuaries because imaging has potential role, because same histology, but if they differ in their location, like the primary DLBCL of CNS is classified together with the DLBCL of the vitreoretina of the testis in the immunocompetent patients as they share their immune privileged sites. However, the same DLBCL occurring in the dura or in the brain vessels escape these immune privileges and are therefore classified separately. So there is a big spectrum of these CNS lymphomas, but however, I will be briefly touching on some of the types due to time constraints. So this is a case 1, a 75-year-old patient with intact immune system was referred to our hospital due to bradykinesias, discrete movement disorder, and low speech for a month prior to the referral. Before admission, the patient developed a broad-based gait disturbance and a pillory tremor, both of which are evident upon examination at the time of admission. So this is the imaging workup which was done. So on CT scan, there was a hyperdense mass in the left thalamus, and then subsequently MRI brain with contrast was performed, in which we can see there is a lesion, not only in the left thalamus, but there's also involvement of the splenium of the corpus callosum as well as the ependymal lining, and the lesions are showing homogeneously post-contrast enhancement, and they are showing homogeneously diffusion restriction. So on radiology, we gave the diagnosis of lymphoma, and on histopathology, the report turned out to be like this: primary DLBCL of CNS, immune competent, and EBV negative. So good to know concepts like, now the preferred term is the primary DLBCL of the CNS, immunocompetent, EBV negative, but unknown etiology because we don't know from where this came. On MR, they are profoundly hypo on T2, and they show marked diffusion restriction. And their diffusion restriction values correlates with the Ki67 proliferation on the pathology. And also pay attention to the prior history of inflammatory lesions. And it has been reported like the inflammatory lesions, like the patients who have been labeled as demyelinating disease, which disappear after anti-inflammatory treatment. They can precede the diagnosis of lymphoma for up to 2 years. So now the current recommendation is if there is a patient who is not fitting into proper category of any pertinent demyelination, so follow these patients for up to 2 years, even if the lesions have disappeared. And look for the shared privilege site if you have a primary DLBCL of the brain. Case number 2, she is a 45-year-old HIV positive female who was non-compliant with medications and who presented with seizures and hallucinations. So we got an MR, and this is T2 weighted MR sequence, and this is post-contrast T1 weighted sequence. So there is a lesion in the left temporal lobe, which is hypointense on T2 with surrounding edema. There's a focus of susceptibility in the edematous region, and the lesion is not showing homogeneous enhancement as we show in the prior scan. And there is a non-enhancing focus in the center. So keeping in view the patient is immunocompromised, she was non-compliant to the HIV medications, we still gave the differential of lymphoma of the immune dysregulation system. And on histopathology, it turned out to be primary DLBCL of the CNS. Patient was found to be EBV positive, immune deficiency dysregulation associated. So case number 2B, this is a contrast enhancing axial MR of a 72-year-old male with renal transplant who presented with seizures and 3 to 4 months of profound personality changes. The patient was on immunosuppressants. So there is a solid or cystic enhancing lesion with heterogeneous areas in the center. So what we did a spectroscopy in this patient just to rule out like if this is a metastatic deposit or if this is an opportunistic infection. So when we did place a voxel on the contrast enhancing solid component, we saw a very high choline peak, and there was a high choline to NAA and high choline to creatine ratio. And similarly, to rule out like this is not a primary neoplastic lesion, we put the cursor or put the voxel in the edematous region, and we saw like there was no high choline peak, and still there was normal glial cells. So on the basis of this, we gave the diagnosis of DLBCL, and this turned out to be DLBCL of CNS, EBV negative, immune deficiency, dysregulation associated. So good to know concept in this. Immune deficiency associated CNS lymphoma, it corresponds to DLBCL of the CNS, EBV positive or negative. Like the first case was EBV positive, and this one is EBV negative. So currently, glioblastomas or NETs are more likely than opportunistic infections in patients with immune deficiency in contrast to the previous decades. Because in dealing with, whenever you are dealing with a necrohemorrhagic tumor, potential immune deficiency and dysregulation must be thoroughly examined. And if this cannot be ruled out, this should be considered. And careful further assessment by advanced neuroimaging like perfusion imaging or MR spectroscopy assessment can provide a pre-surgical diagnostic loop, because we are here to help our surgeons and the neurologists. So this is now included in the consensus recommendations for imaging CNS lymphomas, and it has shown promising results for the pre-surgical diagnosis. So about the advanced neuroimaging, like when we are doing a perfusion scan, we can see there is low to intermediate cerebral blood volume, and there is a high percentage of signal recovery. And this is a characteristic time intensity curve morphology. So the lower CVV values in lymphomas have paradoxically related to a worse prognosis and survival. Now you can see this is the characteristic curve of the lymphomas, in which we can see how fast they are recovering their signal. So what are the distinguishing features of the lymphomas in the immunocompetent and the immunocompromised patients, like the enhancement pattern? In the immunocompetent patient, they are solid, homogeneously enhancing, whereas in the immunocompromised, they're heterogeneous or ring enhancing. Then there's another feature which is known as the internal hemorrhage. So in the immunocompetent patients, there is nil internal hemorrhage, whereas in immunocompromised, it's often present. Typical locations in the immunocompetent is abutting the CSF spaces, whereas in the immunocompromised, it can be lobar, basal ganglia, corpus callosum. And the number of lesions in immunocompetent, they're usually single, whereas in immunocompromised, there are multiple lesions. So what are the advanced imaging features to distinguish between primary CNS lymphoma from their mimickers? Mimickers could be high-grade gliomas, abscess, or radiation necrosis. So on diffusion, the primary CNS lymphoma shows marked diffusion restriction in the solid component, whereas the high-grade gliomas, they show variable restriction, and abscesses are restricted in the non-enhancing central component, and radiation necrosis, there is facilitated diffusion. Relative cerebral blood volume in primary CNS lymphomas, this is mild to moderate increase, but signal is like the recovery signal is high in the primary CNS lymphomas, where high-grade glioma, we know that they show profound increase in cerebral blood volume. Abscess, they have low in the enhancing rim, radiation necrosis, they don't have any relative cerebral blood volume. Permeability is also high in primary CNS lymphoma. That's the reason for their signal recovery ratio. And MR spectroscopy in primary CNS lymphoma shows choline NAA ratio is lower than the high-grade gliomas, whereas as compared to the high-grade gliomas. So there's the case number 3. A 37-year-old lady with cerebral palsy came with complaint of lower limb weakness, progressively increasing towards the right side more than the left. Initial MR brain showed ill-defined T2 flare hyperintensity in the pons and midbrain on the left. In the past, she kept on coming in and was treated with steroids. CSF showed lymphocytosis and negative for any infection. So we have the MR scan of this patient, and we can see like there is an enormous signal intensity in the left hemipons with nodular enhancement, and it's going up all the way up to the midbrain and in the pons. On imaging, we gave the diagnosis of chronic lymphocytic inflammation with pontine perivascular enhancement responsive to the steroids. Its other name is Clippers. It has now it has diagnostic criteria, so probable, possible, and confirmed cases of CLL. So we gave the diagnosis, and patient was kept on high doses of steroids and is doing well. So good to know concepts about the lymphomatous granulomatosis or lymphoproliferative disorder with large atypical EBV positive cells, T cell infiltration, and tissue necrosis occurring exclusively in the immunocompetent patients. In the recent literature, the lymphomatoid granulomatosis has been correlated with CLL with pontine perivascular enhancement responsive to steroids. However, some authors hypothesize like this is a kind of sentinel lesion, while others postulate like this is a response, inflammatory response to the lymphoid tumor cells, which responds to corticosteroids preceding the definite tumor recurrence. Like you need to follow these patients up. So case number 4 is a 67-year-old woman, non-hypertensive in IHD, has multiple hospital visits in 3 months with history of weakness, disorientation, and drowsiness. Initial clinical and neurological impression was a stroke or encephalitis, but in frequent visit, lesions change location and morphology. So these are the MR. On the first DWI sequence, which we had on this patient, we saw like there were punctate diffusion restricted foci in all over the brain. And then there was an enhancing focus dural-based lesion with surrounding edema, which was progressively increasing in size. And on our third visit, we saw like there was diffuse bilateral basal ganglia, subcortical periventricular white matter involvement. And when we performed a spectroscopy and perfusion imaging, that was typical of primary diffuse large B-cell lymphoma. So since there was vascular involvement, we gave the diagnosis of intravascular large B-cell lymphoma of CNS, and that turned out to be diffuse intravascular large B-cell lymphoma of the CNS on histopathology. So this is how it appeared on the histopathology. So what is the good to know concept about the intravascular large B-cell lymphoma? So what happens actually, like they are intravascular, then they come out as they grow and grow, they come out and they make islands into the brain parenchyma. And that is why we could see when they were intravascular, they were doing occlusions and performing as like there is vasculitis or there is a stroke. And when they breach the vessel wall and they form islands within the brain parenchyma, so then we could appreciate like there was a lesion associated with them. So advanced imaging features may include a tumoral pattern of spectroscopy, as well as on the perfusion imaging. So should be kept in mind whenever encountering MR imaging features with hemorrhage and multiple dynamic ischemic lesions on DWI, enlarging parenchymal enhancement and possible associated leptomeningeal or subependymal disease. So you should always keep in mind this could be intravascular large B-cell lymphoma of CNS. So case number 5, a male patient age 51 years without any significant history or prior cranial trauma arrived at the emergency department following spontaneous generalized seizures without fever. The subsequent neurological examination did not reveal a neurological deficit. So on MR, we could see there is a lesion, extra-axial lesion involving the scalp with some flow voids. We can see the permeative pattern of the bone on CT scan. We do not see any destruction on the CT scan, and the lesion has extracranial as well as the intracranial component. So based on the features, we gave the diagnosis of lymphoma, and it turned out to be mild dural lymphoma. So lymphomas arising primarily usually correspond to mild. Occasionally, large B-cell lymphoma may also be primary dural based. A clue for the pre-surgical suspicion of this tumor is provided by the characteristic pattern of the bone infiltration or transdisplosive extension, characteristically enhancing soft tissue mass without bone destruction, normal bone to subtle permeative patterns. This pattern is explained by the extension of the tumor cells through the Haversian canals. So case number 6, a 53-year-old gentleman with above-known comorbids came to us with the complaint of restlessness, irritability, decreased sleep, and increased appetite for 3 weeks. So here we can see there are multiple lesions involving the brainstem, cerebellum, basal ganglia, as well as the frontal lobes with patchy contrast enhancement, and not actual diffusion restriction, but they were low on ADC. So the patient underwent biopsy of the frontal lesion because one of the lesions was more of an extraaxial and it was inconclusive. So then patient came again and there was further increase in the number and size of lesion. So we raised a suspicion this might be in lymphomatosis cerebri. On histopathology, it turned out to be lymphomatosis cerebri. So good to know concepts about the lymphomatosis cerebri. It corresponds to clinical radiological pattern included as the concrete histopathology WHO entity. The typical clinical pre-subacute onset of dementia, cognitive impairment, and personality changes. It consists of non-enhancing or scarcely enhancing T2 flare hyperintense infiltration of the brain tissue, usually located in the white matter regions, with different distributions ranging from focal to patchy or diffuse. And the detection of tumoral pattern or MR spectroscopy or perfusion pattern is the possible enhancing lesions, suppose the pre-surgical suspicion. So the key points or the take-home messages from these presentations are the primary DLBCL of the CNS, homogeneous lesions, hyperdense on CT, T2 hypointense with restricted diffusion. The presence of certain degree of hemorrhage or signs of necrosis should not rule out their pre-surgical diagnosis. In the immune deficiency associated lymphomas, which are primary DLBCL of the CNS, EBV positive, they appear as necrohemorrhagic tumors in the potentially immunocompromised host. And special attention must be paid to the features of perfusion imaging, which may provide findings that suggest lymphoma. Dural lymphoma should be suspected when there is disproportional soft tissue mass without real bone destruction. An intravascular lymphoma and lymphomatosis cerebri may be evolutive diagnosis of suspicion when dynamically changing T2 flare areas of signal abnormality and hemorrhage in intravascular lymphoma are found. And also pay attention to the leptomeningeal and subependymal enhancement. Perfusion imaging and the spectroscopy provide clues of great help in the differential diagnosis of each type of lymphomas. And secondary lymphomas often appear as parenchymal lesions. Isolated leptomeningeal or subependymal disease is characteristic, but apparently less prevalent than formerly assumed. So that's all. Thank you very much.
So Dr. Fatma Mubarak is online if anyone has a question. Anyone? It's fine, I'll go ahead with the question then. Can you hear me, Dr. Fatma?
Yes, Shahzad, I can hear you.
Necrosis within lymphoma, how often do you see it? And any value of T2 flare mismatch in lymphomas?
No, like I haven't come across any value of T2 flare mismatch in lymphomas. But yes, over time, I realized, like initially when I was a resident, we used to say like if there's a hemorrhage in a lesion, it cannot be lymphoma. But over the years, I realized, yes, this can be a lymphoma, and then we should look at the immune status of the patient.
Okay. Prof, can we discard glioma as a, lymphoma as a possibility if it's a small lesion that has a central necrosis? Sorry, you can come here.
The problem is that we don't often have the treatment history. So if they are immune competent and treatment naive and have necrosis, you're probably not dealing with a lymphoma.
Okay.
But if you do not have the treatment history, and a lot of people get steroids before they even come to imaging.
Okay.
So if you do not have the history and you don't know the immune status, then of course not.
Okay. Thank you so much, Dr. Fatma. One last question. ADC values. Any value? For
Actually,
lymphomas?
different scanners have different values, but you can
Okay.
compare it from the contralateral side. But the lower the ADC value, the lower the prognosis. The bad
The
prognosis
worse the
is.
prognosis.
Yes, yes.
Okay. Thank you so much, Dr. Fatma. That was excellent. Very, very helpful. Thank you for your presence. So next up is Dr. Ammar from Beth Israel, Boston. He is going to talk about something of Dr. Amir's interest. It's Y90 treatment in liver cancer. That's yttrium 90.
Assalamu alaikum, everybody. Thank you for the organizers for inviting me to speak on radioembolization for hepatocellular carcinoma. These are my disclosures. I'm the site PI for 2 FDA trials and a consultant for a couple of companies in the Y90 space. So let's start by talking about the basics of radioembolization. Radioembolization is an intra-arterial brachytherapy. It's both radiation therapy as well as embolization for hepatic malignancies, and it uses this ionizing radiation to kill cancer cells. They place tiny glass or resin beads through intra-arterial administration directly at the tumor site, and it takes advantage of the dual blood supply of the liver, with most of the normal liver being supplied by the portal vein and most of the tumors being supplied by the hepatic artery. There are two main devices on the market, Theraspheres and resin microspheres. Theraspheres are glass microspheres, and Surspheres or Surtex are made with resin. And then there's a new product in the market, which is a radio-opaque glass microsphere that is being developed and tested in clinical trials currently. Y90 causes pure beta emission at about 0.93 million electron volts. Its half-life is about 64 hours. And from where the beads land inside the tumor, the average penetration of the radiation is about 3 millimeters, with a maximum penetration of about 11 millimeters. The brachytherapy implantation technique takes advantage of the fact that the liver tumor vessel diameters are between 25 to 75 microns. And then the resin or glass microspheres are about 30 microns. So they're too large to pass through to the capillary bed within the tumor. Therefore, they become permanently implanted inside the tumor. The indications for radioembolization in general for hepatocellular carcinoma includes for BCLC-A disease techniques such as radiation lobectomy or segmentectomy, BCLC stage B and C disease, usually patients without extrahepatic disease or with only a lot of liver disease and very little extrahepatic disease, cholangiocarcinoma, and then metastatic colorectal cancer. Although this use has mostly moved to the salvage setting for metastatic colorectal cancer. This is the latest update of the BCLC algorithm, and radioembolization has now been included. It's one of the few local regional therapies that's included in the BCLC algorithm. Currently, it is usually recommended for single lesions less than 8 centimeters as far as the guidelines are concerned, and for patients in whom ablation, resection, or transplantation is not feasible or there's failure of these techniques. However, in clinical practice, for patient selection, typically the patients selected for hepatocellular carcinoma are patients with the tumors that are not surgical candidates. There's presence of liver-only or liver-dominant disease. The performance status is less than 2. Life expectancy is more than 3 months. Usually, in most cases, the bilirubin should be less than 2 milligrams per deciliter. Lung shunt fraction should be calculated by an MAA study, which I'll explain in a few minutes, and should be less than 20%. The overall lung dose that's tolerated by patients is less than 30 gray to the lung one time and less than 50 gray lifetime. There are some relative contraindications, although expert centers have treated patients with all of these contraindications. This includes contraindications to angiography, such as if they're allergic to dye, if there's an ongoing infection, pulmonary insufficiency, a bilirubin greater than 2, if there's been previous high-dose external beam radiation therapy to the liver because of the risk of radiation-induced liver disease, and biliary enteric anastomosis or stents, such as a hepatic angiostomy, because this can cause colonization of the biliary tree and predispose the patient to abscesses after radioembolization. However, these patients can be treated with pre- and post-procedural antibiotics. Usually there's a 4-step process with labs and imaging, followed by clinic consultation, a mapping arteriogram, and a treatment arteriogram. Let's look at a mapping arteriogram. Patients usually come in for this outpatient procedure where diagnostic angiography is performed, either from a femoral or a radial approach. The angiography is used to look at the vascular supply of the tumor, which we can see over here down in the bottom left of your image. And then we make sure that there's no vessels that are supplying extrahepatic structures such as the gallbladder, the bowel, or the diaphragm. And if those are close to the treatment positions, those are treated with coiling. Next, the lung shunt fraction is determined by injecting technetium-99 MAA. These particles are about 10 to 90 microns and considered to be surrogates for the radioembolic beads. 1 to 4 millicuries injected via the hepatic artery catheter to mimic the treatment position, and the lung shunt fraction is calculated. The amount of activity that we prescribe is dependent on the lung shunt fraction. So here is an example of a patient on the left where you can see high scintigraphy inside the liver from the hepatic artery injection with very low amounts of counts in the lung. This image on the other side shows a different patient with a large amount of activity within the liver, but also some uptake in the lung with a moderate lung shunt fraction. Once this has been done, the patient is scheduled for a treatment arteriogram. These are how the vials are shipped from either Singapore or from Germany on their way, for example, if they're coming into Pakistan. This is what the V-vial looks like. The V-vial is drawn into a prescribed activity for the SIR spheres by your nuclear medicine lab. And then the patient, it's taken to the patient. Here you can see a catheter going into the patient's groin. This is on the day of administration. And these tubes are set up in order to perform the administration. Once the administration has been completed, post-Y90 imaging is performed. So this is an example of a patient who had 4 tumors. These are 2 over here, and they had 4 different segmental therapies as part of a single administration. Here you can see tumor number 3, and that's tumor number 4. And then here you can see on this post-Y90 PET-CT, very high localization of the radiotracer in all of the relevant domains. Post-Y90 imaging is also relevant because it can show areas of underdosed tumors. So for example, here you can see a faintly arterially enhancing tumor with gross washout. This is the post-radioembolization scan, but clearly there's under delivery of radioactivity in this region over here. And that's where on the 3-month response, there's arterial enhancement and washout and residual disease. One of the important techniques for performing radioembolization is known as radiation segmentectomy. This is a radiation technique with a curative intent. It's when tumors or the treatment is localized to less than 2 hepatic segments. And usually we're trying to give a 250 to 300 gray target absorbed dose. This technique was established based off of the Legacy study, which was a single-arm, multi-center HCC study at 3 US sites. Radioembolization was performed using glass microspheres. They enrolled 162 patients, out of which 45 eventually underwent liver transplantation, and 50 patients only needed 1 Y90 treatment alone. You can see here that the objective response rate was extremely high, almost 88%, with 84% complete response rate in localized embry cyst and 82% in non-localized embry cyst. In the Legacy trial, 84% of patients experienced no progression at 24 months per embry cyst. So single treatment for less than 8 centimeter tumors and no progression at 24 months. And for the entire group, the overall survival was 95% and 86% at 24 months and 36 months, establishing it as a very effective primary therapy. The RAZOR trial was another single-arm prospective trial. In this trial, 24 out of 29 patients had a complete response, and an objective response rate was 100%. Only 3 patients had target lesion progression. That's 8 months, 16 months, and 22 months. And 6 patients had non-target progression at a range of 181 to 700 days. So radiation segmentectomy was first published by Dr. Reyes from Northwestern in 2011. And then updates were provided in 2018 and 2021, and most recently in 2022. Most of these updates changed how the dosimetry was performed. So it used to be that the dosimetry was performed using 120 gray target absorbed dose, but now the target absorbed doses are up to 775 gray, which compare quite favorably compared to radiation, external beam radiation therapy. This study that our team published recently this year in the journal Radiology looked at 67 patients with hepatocellular carcinoma who were treated with radiation segmentectomy using Y90 resin microspheres. The median tumor dose was 232 gray, And 88% of patients had a duration of response more than 1 year, meaning that they had no progression at more than 1 year after treatment. The objective response rate was 94% at 6 months. 88% of patients had a duration of response of 1 year or greater. Median overall survival was not reached for the patients who were treatment naive or did not have vascular invasion. So this is the green line. It's the patient who underwent resection or transplantation, and the orange line is patients who were receiving treatment for the first time. In blue, the 23-month median overall survival was seen for patients who had received other treatments before receiving radioembolization, which kind of indicates that more and more patients should be trying to get this treatment primarily. No patients experienced treatment-related adverse events during the study period. There is a case example from Beth Israel. This patient had this large hepatocellular carcinoma in the left lobe. This is the first post-therapy scan. And then, as you can see, as the time resolved, as time goes on, this area of radiation shrinks down to completely normal, where up to 5 years later, the patient is completely disease-free, and that tumor has completely gone away. Radioembolization is also very effective in the advanced setting. Early on, from 2010 to 2016, there were two randomized controlled trials of Y90 versus sorafenib, which were performed, which were negative, the SARA trial and the SURVI-NIB trial. However, both of these trials used resin microspheres dosed using the body surface area model, which we have since learned underdoses tumors. We learned this through the Dososphere study, which was published in 2021, in which 60 patients were randomly assigned to a personalized dosimetry group compared to a standard dosimetry group. And you can see here how in the personalized dosimetry group, the amount of radiation dose was much higher compared to the standard dosimetry group. With this higher dose of radiation, there was a survival benefit seen of about 26 months median survival for patients with advanced stage hepatocellular carcinoma with portal vein tumor thrombus compared to the standard dosimetry arm. In this trial, which was published in the Lancet Gastroenterology and Hepatology, it was also found that 11 out of 60 patients were downstage to curative resection. And nearly all of these patients were in the personalized dosimetry arm and underwent R0 resection despite having portal vein tumor thrombus, demonstrating that personalized dosimetry can provide neoadjuvant curative radioembolization for patients with advanced hepatocellular carcinoma. There's also some benefit that could be found with combining Y90 with immunotherapy, although this is currently the subject of clinical trials. This is a case example of Beth Israel, of a patient with a hepatocellular carcinoma who was referred to us from Bermuda and had a large, let me just play that again, had a large left lobe hepatocellular carcinoma with portal vein tumor thrombus, as you can see over here. In addition, this patient also had lung mets. Our recommendation was to give radioembolization for the liver tumor and then start the patient on nivolumab. The patient's main desire was that his daughter was getting married in about 12 months, and he wanted to make sure that he could make the wedding. So this is the radioembolization that was given, high dose of radioembolization to the left lobe. You can kind of see the uptake within the portal vein tumor thrombus, and the patient was then started on nivolumab. 2 years after treatment, the patient's left lobe had completely scarred down. The lungs were completely clear from tumor. This patient had derived benefit from the abscopal effect and was able to take have his daughter married off and actually is still alive almost 5 years later and completely disease-free. So radioembolization has been available in Pakistan since June 2021. So this is the scan of a patient with right lobe disease and portal vein tumor thrombus that you can see on the axial images on the left, but is also visible on this coronal image on the right. A planning arteriography was performed with a hepatic artery angio-CT, where the patient is transferred from the angio suite with a catheter inside the hepatic artery to a CT scanner. This is used to calculate dosimetry calculations. The lung shunt fraction here was very low, about 1.3%. And here's the post-treatment scan, which shows that the main portal vein is entirely patent and the treated portal vein branches are no longer enhancing and dead. Radioembolization requires an interventional radiologist who is credentialed to provide radioembolization. Although this technique is similar to chemoembolization, it is not exactly the same, and dedicated education in radiation treatment through a Y90 course is recommended. Typically, this requires 3 proctored cases and approval for the interventional radiologist from the Pakistan Nuclear Regulatory Authority as a treating physician. Since July 2022, all cases performed in Lahore at least have been performed by Dr. Adil Asghar at Doctors Hospital, and more than 30 patients have been successfully treated by this program. I think it would be tremendous to start more radioembolization programs in Pakistan, and I'd be happy to help any center that's looking to do this. It requires dedicated training for physicians and paramedical staff, developing a collaboration with Diagnostic Radiology, Nuclear Medicine, and Tumor Board, approval from the Pakistan Nuclear Regulatory Authority for the hospital as well as for treating physicians, selection of the device, and there are 2 devices that are currently available in Pakistan, Certex Medical and Boston Scientific, and then selection of a clearing agent and import mechanism, because these vials decay quickly, and so you want to make sure that you're ready to deliver them when the dose arrives. So I think in conclusion, radioembolization is a highly effective therapy for advanced and localized liver cancer using either radiation segmentectomy or personalized dosimetry for advanced disease. Given the high disease burden for hepatocellular carcinoma in Pakistan, there's the need for at least 3 to 4 centers of excellence for radioembolization. It requires careful patient and angiosome assessment to make sure that you're mapping the vascular territory of the tumor, detailed planning arteriograms with cone beam CT or angio-CT as available, and knowledge of absorbed dose thresholds to guide activity calculation. Thank you. Once again, I really appreciate the invitation to speak at this prestigious symposium. And if there's any questions, here's my email address. Feel free to contact me.
Dr. Amar is online.
Thank you very much.
Dr. Amar, can you hear me?
Yes, I can hear you.
Okay.
Thank you for having me.
I'm Dr. Abdul Wahid, oncologist from Peshawar. Thank you, Dr. Amar, for this new technique, especially this brachytherapy in the case of CR liver. We in Pakistan, as you told, we have got a lot of cases of carcinoma liver, and some of them are very much advanced, and some of them they are multifocal. So my questions, short question, one is what's its role in the case of multifocal? One. Second thing, the dose to the lungs you told about 30 gray dose to the lungs, which looks very much high. If it's, that can cause radiation pneumonitis. And the third question is that can we add chemotherapy along with this, just like in TAST, please?
Jazakallah for the question. So I think for your first question for multifocal disease, I think it depends if it's unilobar or bilobar. For unilobar disease, you can do a technique known as radiation lobectomy, which actually shrinks down for example, if you treat the right lobe and causes the left lobe to hypertrophy. And so you can very safely give very high doses of radiation. In bilobar disease, I would not recommend bilobar treatment, which means that treatment from both right and left hepatic arteries. Usually, some centers will separate that treatment about 1 month apart. but more expert centers. And what I would recommend is that even in multifocal disease, you can actually treat, let's say, 4 or 5 out of the 8 hepatic segments, because the tumors are typically not localized to every single segment. So there's a way to do individual segmentectomies of the 5 or 6 involved segments in bilobar disease. But yes, it can be used for multifocal unilobar or bilobar disease. You just have to be careful with the treatment strategy that you use. The 30 gray number has been established for about 20 years for radioembolization. And this 30 grays is not similar to the 30 gray that we give in external beam radiation therapy, for example, because the dose rate for radioembolization as a brachytherapy technique is extremely low compared to the dose rate of external beam radiation therapy. But this number is very well established. I will say with hepatocellular carcinoma, outside vascular invasion, it's very rare to find patients who will receive more than 3 or 4 gray to the lung. And so, but this number is established and part of the guidelines. And then for your third question, yes, Y90 can be combined with systemic therapy. Usually, so right now, the trials that will prove the benefit of this approach are underway. But usually what will be done is either the Y90 or the radioembolization is given first, and then the patient, after 1 or 2 weeks of recovery, is started on immunotherapy or systemic therapy. Or you start, if the patient is already getting immunotherapy or systemic therapy, then you take about a 2-week break, start the radioembolization, and then after another 2 weeks, you can restart the systemic therapy.
And what about what they're combining doxorubicin with this yttrium, and at the same time and the same go, just like in TACE, please?
That hasn't been tested, but it's not necessary because most patients, 80 to 90% of patients who get radioembolization and then get surgical resection, they don't have any living tumor cells in their resection specimen. So Y90 by itself is extremely tumoricidal, and it can kill cancer cells down to the microscopic level.
Okay, thank you.
There's
Anyone
a
else?
question in the chat, which is there any head-to-head trial between TACE, RFA, and radioembolization? So there are 2 randomized trials between chemoembolization and radioembolization. One was the TRACE trial that was published in Radiology a couple of years ago, and then the other was the PREMIER trial. Both of these trials were stopped early because they showed a tremendous benefit in the radioembolization arm compared to chemoembolization in recurrence-free survival as well as overall survival. There have been no studies right now comparing thermal ablation to radioembolization. Those techniques are considered complementary, and so according to the BCLC guidelines, only if RFA is not able to be performed should we do radioembolization.
Any other question from the floor? Okay, thank you, Dr. Amar. That was very, very good and an important one. I hope you get the opportunity to come and set it up in more hospitals. So we're spot on time. As we conclude the imaging section of the 23rd Symposium, I would like to extend my heartfelt thanks to the guests that made all the way from Karachi and Peshawar, and I extend my thanks to the moderators as well. Thank you very much. And everyone that's here, I hope that it was as helpful and educational for you as it was for me. Thank you very much and enjoy the rest of your day.